Hi, my name is Madison Snikovsky. I'm a registered nurse with a Bachelor of Science in Nursing, and I've been practicing for 5 years. The topic I chose for my synthesis project is improving medication adherence in adults with type 2 diabetes. I chose this topic due to diabetes being a common chronic condition that I encounter within my work. Oftentimes, it includes a multitude of complications that result from non-adherence to medication regimens. This presentation will highlight the significance of this problem, propose a PCOT question, outline a search strategy and its results, and provide a synthesis of the literature. I will then identify the setting in which this practice change will be implemented, including an evaluation plan, data collection, and analysis methods, as well as a plan for dissemination. The World Health Organization reports that adults over the age of 30 diagnosed with type 2 diabetes have a medication non-adherence rate of 59%, which highlights the prevalence of this problem. The most common reasons given by patients for medication non-adherence is simply missing the medication or not understanding how to properly take the medications. Non-adherence to diabetic medication results in poor disease management, increased hospitalizations, secondary complications, and an increase in healthcare expenditure. Some of the secondary complications from medication non-adherence include organ failure, neuropathy, heart attack, and even premature death. To emphasize the significant healthcare expenditure in relation to diabetes, in 2017, the United States spent roughly $237 billion on diabetic medical costs. When comparing patients that are compliant with their diabetic medications to patients who are non-compliant with their medications, non-compliant patients were found to have an increased average healthcare cost of $4,000 every year. The focus of my project is guided by the following PCOT question. In adults with type 2 diabetes, does participation in a structured digital intervention program, such as telehealth support, compared to patients receiving standard care without digital resources, improve medication adherence as measured by pharmacy refill records over a 1-year period? To find literature relevant to my topic, I used multiple steps within my search strategy. I used key terms such as diabetic medication adherence and treatment adherence diabetes. I also used telehealth support type 2 diabetes and a few others. I used mesh terms such as telemedicine and medication compliance, and I also included filters such as academic journals, peer-reviewed, and past 5 years. Most of the literature resulted from Gale Academic OneFile, Medline, and Science Direct. I also included information that was found within the U.S. Center for Disease Control and Prevention, as well as the World Health Organization. The literature found within my search strongly supports telehealth interventions as a suitable method for improving medication adherence among type 2 diabetics. I've included some significant studies. One of these studies examined remote monitoring via telehealth over a 12-month period and saw a 6.4 increase in diabetic medication adherence. Another study evaluated satisfactory glycemic levels. The intervention that was implemented was two-way communication telehealth, such as mobile apps, calls, and video conferencing. After the 12-month period, the group that received telehealth services had almost 63% satisfactory glycemic levels, whereas the comparison group that only received standardized diabetic care without the use of telehealth only had roughly 32% satisfactory glycemic levels. I am proposing the implementation of the use of telehealth services into standardized care for adult type 2 diabetics within the primary care setting, and this is supported by my synthesis of the literature found within my search. Collectively, the literature focused on telehealth support interventions as it relates to medication adherence in type 2 diabetics. Some of the common interventions that were used were remote patient monitoring, two-way communication such as video calls, text messaging, e-health portals, as well as telephone-based health coaching and health literacy mobile applications. All of the studies had Johns Hopkins ratings of A or B and levels of evidence between 1 and 3. All studies implemented these common telehealth interventions and were consistently shown to have a positive impact on medication adherence within a type 2 diabetic patient. Additionally, the populations and comparison groups were consistent with minimal to no variability. The population was type 2 diabetics 18 years of age or older, and the comparison group had the same population, however, they received standardized diabetic care without the use of telehealth. So this would be medication management and counseling that was provided during routine face-to-face provider visits. A common gap I found within the systematic reviews regarded fidelity. Many of the studies assessed outcomes based on patient self-reporting or unclear standard protocols, and few of the studies provided pharmacy refill records. Substantiating the research by providing records of pharmacy refill would further support the results of the studies as opposed to patient self-report. While further research may be necessary to identify which telehealth intervention would provide the most optimal outcome, the consistent trend within the literature provides that telehealth interventions are an effective method of improving medication adherence among type 2 diabetic patients. The setting in which I am proposing the practice change is a primary care setting where most diabetic visits and standard care for diabetes takes place. The practice change would be implemented using Cotter's 8-step change model. So first, I would highlight the prevalence of medication non-adherence in type 2 diabetics, as well as complications that can result and healthcare expenditure. Then we would establish the multidisciplinary team, including primary care providers, healthcare staff, facility administrators, quality improvement, and technical support teams. Next, we would create the vision for change. So this would be implementing telehealth for type 2 diabetics into routine diabetic care to support education, follow-up, medication management, and overall improved medication adherence. We would then discuss timelines for implementation to include training, potential changes to protocols and regulations, desired outcomes, and how the workflow will change. The next step in Cotter's change model is removing obstacles. So we would identify and minimize barriers to telehealth implementation by providing staff trainings, shifting workflows, and allowing open communications to determine realistic and manageable methods of telehealth implementation. Next, we will create short-term wins. So that would be enrolling a pilot group of patients into the program with the goal of achieving higher patient satisfaction rates, improvements in medication adherence, fewer no-show appointments, and increased patient engagement. Once this is accomplished, we would expand the implementation to the remainder of type 2 diabetic patients while continuing to evaluate outcomes, patient and staff feedback, and workflow efficiency. Lastly, we would integrate telehealth support into the standard of diabetic care throughout the facility, ensuring effectiveness of the intervention and staff competency of the program, and enforcing established protocols regarding the new telehealth support. The outcomes that will be evaluated after this implementation are patient engagement, post-intervention glycemic levels, and pharmacy refill records. Patient engagement with the telehealth program is relevant in determining its clinical significance of outcomes by demonstrating the consistency of patient utilization and can further support its benefits if higher utilization is associated with improved medication adherence. Additionally, improved glycemic control is positively linked to medication adherence. and pharmacy refill records are a practical method of determining levels of medication adherence among patients. These outcomes will be measured through attendance rates, reductions in hemoglobin A1C levels, and pharmacy refill records, proportion of days covered, and medication possession ratios. Data will be collected and measured utilizing analytics from the telehealth platform to identify engagement activity as well as attendance rates. Additionally, hemoglobin A1C levels as well as proportion of days covered and medication possession ratios will be collected at baseline, 6 months, and 12 months. Tests to evaluate the changes in outcomes will include the paired t-test, as well as the analysis of variance, otherwise known as ANOVA. The paired t-test is an effective measure of comparing pre- and post-intervention outcomes, such as medication adherence. And ANOVA is used when 3 or more groups are present for evaluation, for example, assessing outcomes at baseline, 6 months, and 12 months. Plans for dissemination includes institutional, local, and regional venues. At the institutional level, we would hold a meeting with quality improvement, facility leaders, and organization administrators to share the evaluated outcomes of the implemented telehealth support program through formal presentation. At the local level, we would meet with community health departments, primary care clinics, and hospitals to present the data that was collected from the practice change. We would also publish flyers throughout the community to increase knowledge regarding the accessibility of diabetic care through the newly implemented telehealth program, as well as the outcomes that were achieved through this telehealth implementation. Regionally, we would collaborate with the Florida Nurses Association events team to present outcome findings of the telehealth support in relation to type 2 diabetic medication adherence and request for a formal presentation of the findings at FNA conventions and meetings. Throughout this presentation, we discussed the prevalence of medication non-adherence in type 2 diabetic patients and identified the significant problems that are associated with this, such as patient complications and healthcare expenditure. Relevant to the PCOT question, I provided the search strategy and its significant findings. After performing a thorough synthesis of the literature, I proposed my clinical practice change recommendation of implementing telehealth services into the standardized care of type 2 diabetics within the primary care setting. I presented a plan for implementation using Cotter's 8-step change model and developed an evaluation plan with outcome criteria and measures. We identified data collection measures and statistical tests that will be used for analysis. Finally, I developed a plan for institutional, local, and regional dissemination of the outcomes of the practice change. Thank you for taking the time to listen to this presentation, and I would love to hear from you in the peer feedback if you have any questions. The next 3 slides are the references that were used to complete this presentation.